So I have made Kirti, Dr. Funny, and Dr. Hassoon co-hosts so that you can share what I'd like us to do is apologies. I just need to shut off the echo. My apologies about that. So what we're going to do, I'm going to take 5 minutes to basically take you all through logbooks, just because from my perspective at the moment, I have gone through and I will be signing off. I've signed off quite a few, but I will be signing off all your logbooks by Wednesday. I think virtually everybody from my perspective who's maintained a structured logbook is doing it well. And some of you are saving your PowerPoint presentations, but I can't, I credential them. So what I'd like us to do is just go through how to make it easy for you, very easy for you to be able to do in a structured way. But some of you have also wanted to discuss how you store images, which is very, very easy. And which actually, once you PDF the file at the end of whenever you want to stop keeping your logbook, it just keeps a record of everything in a very nice way. So first of all, can everybody see the logbook?
Yes.
Yeah, we are able to.
Yes.
Okay, excellent. I'm going to make a start. Just a humble request, Dr. Kirti, if you see anybody in the waiting area, then if you could let them in as co-host, because once I start talking, unfortunately, my brain doesn't multitask. So is that okay?
I don't know how to do that.
Okay, no problems. I'll keep an eye on it. I will multitask today. Maybe I need to learn how to multitask.
Alok.
Yeah. Yeah.
Please make me co-host and I would let people in. So that's
Sure.
it. Yeah.
That's really kind. So I will make you co-host. I can find where you are.
Alok, I think I am already made co-host, so I think I can keep admitting.
That's fine. What I'd say is that between you and Dr. Doris, I think just making sure. Yeah, that's fantastic. So can everybody see the logbook as a first?
Yes.
Okay,
Yeah.
excellent. That's beautiful. So this is your logbook. Now, in your logbook, obviously, from your perspective, there are certain competencies. The dates that you have initialed them, you enter here. And I enter an observed date, which basically says that, yes, I've seen it. And then I basically credential it as an independent trainer sign-off. Now, clearly, from our perspective, once you've been able to cover assessment and diagnosis and reporting of all the pathologies that are entailed over here at some point. And I don't want you to feel too stressed about it, because I know that not everybody is going to be able to see a case of congenital diaphragmatic hernia. For me, the credentialing for you as an L2 observer means that you have to diagnose 4 pathologies for me. They are RDS, TTN, pneumonia, and from my perspective, the fourth diagnosis, meconium aspiration. I think if we can get images to show that you can confidently make clinical correlation and diagnosis of these 4 pathologies, I'm very, very happy. I think the second aspect to it is storing your images. Now, storing your images is very easy. First of all, it has to be anonymized. So nothing should be able to identify the baby, but technically nobody will be able to identify a 26-weeker who's 660 grams, because all over the world, there'll be millions of them who are delivered. What we do need, however, from you is, an indication, any significant findings, and just a reflection. And a reflection basically from your perspective is, and I'll share my logbook with you, it's just what was there about the image that you improved? Was it something related to the image quality, image pattern, or was it that you had a diagnostic kind of conundrum and we changed diagnosis a little bit based on it? But in order to store, it's quite easy. So once you've done that, my advice would be that you keep the PowerPoint presentations. And the reason you keep the PowerPoint presentations is because they keep the history, they keep the images stored. They're stored as clips as well. But more importantly, it's easier to embed a PowerPoint. And how do you do that? So from our perspective, if you go to the top here, I'm just trying to show you. My screen is coming into view. Is you have an insert function over here, which basically allows you to insert images. So for those of you who want to, I have no problems. You can save images as well. But really what you'd like to do is save either the videos or the loops or the PowerPoint presentation. And for that, what I'd say is what you've got to do is you've got to insert object. And when object comes up, there are two ways to do it. You can either create from file, press browse, and basically select your PowerPoint presentation. Now, just be very careful of using the same name for your PowerPoint presentations, because what sometimes happens is if you name a file 1 and the next file you modify, you save a new case, you save it as 1, then what happens is you get all ones over here and it gets very confusing for anybody who's looking at the logbook. So what you want to do is like somebody in WhatsApp. Okay, lovely. So what you want to do is insert them, and I would rename the files in the order in which you're doing them. So one way is that you index them as 1, 2, 3, 4 Roman numerals or numbers. But the other way, from our perspective of doing it, is you can anonymize them by patient file. So what I've done is I have a library of all my images which are completely anonymized. They can't be identified. But you do have to clinically correlate and say, for example, if you want to use them for teaching purposes, which I'm sure all of you are doing so well in your imaging, you'll want to do. Then in that situation, it's sometimes easier for you to actually keep the patient credentialing in a way that can't identify the patient. And I just use an alphabet with a number. So A1, A2. So it's up to you how you want to do it. But inserting from it basically is creating from file, browse, insert. When you insert like this, it will take time. So be patient. If you have 3 cases or 5 cases, it can take 5 minutes for it to insert. The other thing is your Word file will become very heavy. Now, nothing to worry about. So, from my perspective, what I'd say is that in your Dropbox account, we have a lot of space. So once you save it there, what I'd say is when you continue and you finish and you decide that, fine, I've saved and I'm not, I feel confident about my logbook and stuff like that, I would advise that you PDF it. And the way to PDF it is basically to file and save as Adobe. And what it'll do is it'll PDF it into a file, which basically saves everything, including the videos and the files. It will say enable media, and all you have to do is press media, and that becomes your logbook for life. I think keeping it very important. So I'm just giving you a simple example. Today, Doris got a little bit worried because she lost her file. So what I'd say is that it's always having backup servers for any logs that you're keeping. So I basically back up virtually 11 terabyte of data on 3 different drives. And that is very, very important. Any questions about that? I've got Naz who's raised her hand.
Hi, Alok. I'm just going back to the initial bit. So it's got observed and supervised. So I understood that observed is that, like, we've seen a case or we've discussed a case that way. So you observed it, and then supervised is you've actually done it. Am I right in that?
No. Supervised is basically, observed is we've seen it, discussed it, and basically because we've discussed it, I can now initial it.
Okay.
And that basically means that 2 clinicians, and normally what happens is there are 2 peer reviewers as part of each of the groups. So like Nadia's going through your cases, but I'm also going through the cases every Sunday. So what I will do is I will initial it over here. Now, supervised might mean that somebody has achieved a level of proficiency, probably still a little bit more practice in order to be able to kind of get the confidence or the ability to do it under indirect supervision. A simple example is we're going to discuss a lot of cases today, and that will give me a good feel of how well you're able to interpret these things. So that is a good way of looking at the learning breadth. So once we feel happy about that, we sign and date that, and that then basically means that actually from your kind of perspective, you have 2 trainers who've independently signed you off as being able to clinically diagnose and manage a pneumothorax. Do you get what I'm saying?
Yeah, thank you.
It's more the progress. The risk of kind of saying that we did one DOP, we signed off a DOP, and that kind of means that we're capable of putting a PICC line in every baby becomes a little bit tricky. So we need a little bit more kind of depth and analysis, which is what we're going to gain in the workshops. So, and for those of you who can't attend, please do not feel worried. There will be workshops repeated. So we will be discussing cases like this again and again and again, and you'll get a lot of opportunity to be able to critique. So I've got Dr. Sharif, whose hand is up.
Yes, Alok. Just quick question about when we insert the object.
Yeah.
So the way I'm doing it, like I got my logbook
Yeah.
from the website. I download it as a separate file on my drive.
Yep.
And I try to insert object, but something has come. But now you make it clear. But how are you going to see these images if I'm putting it in my drive on my laptop? In drive C, for example, how are you going to see these images?
So when you insert the object as a PowerPoint, and that's the beauty of it, the PowerPoint will have the images and the media enabled. So in old sections of Microsoft, below the current version of 365, it will ask you to enable media. So you'll have to enable media, but in the new version, it automatically stores them as media. So if they're images, get stored as images. If it's media, get stored as media. And really what I'd say is a simple example, like sometimes files can get corrupted. The most common reason for them getting corrupted is you haven't waited long enough and you've tried to close the file or close your Word document. So you get a partial download. So what I like to do is once it's kind of stored and inserted, I just double click on it and open it. And basically I can see the file again and I can see the media inserted.
Oh, yes. So you can have access to it anyway.
Yep. But all the cases I'm sharing with you at this particular point, which I'm anonymizing, they're all from my logbook.
Yeah, sure. Oh, yes, I see. And what is a drive? You said the Dropbox, sorry.
So what I'd say is that you can back up on your laptop. You can back up on a USB. But let's say your laptop, like my cats decided to one day have a little bit of fun with my laptop and basically destroyed it. So that kind of meant that if it's not backed up, it risks you having a lot of data. So what I'd say is back it up somewhere. And most people have a OneDrive or a Dropbox account of some kind where they basically keep the images and everything backed up. The safest way to do it is, I would say that OneDrive and Dropbox are the most common, but you can use Amazon, which is the cheapest and actually confirms with all regulations in terms of security and safety. All three are very, very good.
Sure. Thank you.
I have the lovely Doris. You're all lovely, but yeah, Doris is extra special. Yeah.
Thanks, Alok. Just to clarify, I'm following on from the question that Naz was asking about observed and supervised. So these lectures that we're having, we're observing images. Can we put that down?
Absolutely. Absolutely.
So observed.
Yeah, completely. And really, like we're doing a workshop today and that's the beauty of having these sessions recorded. So because we're recorded, I can actually go back through the sessions again just to refresh my memory. And I do that every Sunday. It's a real investment in time because, the peer review sessions are they're nearly an hour. And what we're trying to do is keep them to about 30 to 45 minutes. But really, that's my kind of aid memoir of what have we discussed and what do we feel. The difficulty that I am going to have, and that's why I'm raising the logbook today, is that some of you are maintaining it very nicely, but some of you are just putting the PowerPoints there. That means that even when you do your logbook, I will have to go back if I don't remember. And can you see how that is going to make life quite difficult? I mean, it's good for learning. You go back and you watch. And, I've trained under Dr. Suryavanshi. I mean, he's absolutely amazing. And I still go back and watch his videos again and again and again. And so, but I just, I'm just putting it out there that I think if you want to really maximize it, I would say try to maintain the logbook and embed your images so that we can do sign off. Your first sign off is due So for all of you, I think you will be getting your L1 certificates by the end of this week.
Okay, sorry, one more question, Alok.
Yeah.
And now the scans we do that are peer reviewed. So where do we put the date under observed? Or
So you put the date that you feel you've achieved it.
under observed.
Under observed. I will basically date and time it and put my signature under supervised. But
Okay.
say, for example, a simple example is pneumothorax clinical correlation. And what I'd say is it's clinical correlation and management. So really the clinical correlation, the diagnosis, we'd be able to sign off as competent to perform, but really for the procedural sufficiency, saying that you're actually using it as a diagnostic purpose, we really need to populate this under the diagnostic category to say you've done diagnostic paracentesis. So when you achieve that, whenever you achieve that, that could be a year, maybe 2 years from now. Hopefully I'll be alive at that time and we can have a chat. We can discuss the images and we can credential at that time. So it's not an issue. What I'd say to you is don't feel too anxious that, and I'm going to be very frank with you, I do not use lung ultrasound for congenital lung other than CDH because I just do not have the ability to do it. So actually, from my perspective, that's something that I've never achieved, but Nadia has given such a beautiful talk on it. So now I will go forwards with it. And when I have an image like that, actually what I will do is I'll go and pick Nadia's brains and say, and that's what I've done with the CDH case. So really, that's the way to kind of move forwards with your logbook. It's work in progress. And my experience is, I mean, I still keep logbooks for all my echoes, all my lung ultrasounds, all my point of care kind of line related ultrasounds. The only thing I don't keep a logbook for is head scans, because we do so many that I think we might die if we start doing it over here, at least in the Corniche.
Okay.
Kirti, you have a question?
So amongst all of these columns, we only need to fill in observed. We leave supervised.
That's correct.
Okay.
Yeah, that's correct. And really what I'd say is that my experience is that most of you will cover everything in this 6 months without any problems. But a good example would be, my gut feeling is you'll also see a diaphragm, but in terms of needling and putting a chest drain in, it'll be interesting to see at what stage you feel confident enough to be able to do that with or without a chest x-ray. That's absolutely fine. We have no problems. If you use lung ultrasound, you then did a chest x-ray, you needle observed, that's good enough for us in terms of clinical correlation actioning. If you are doing a lung ultrasound for diagnostic paracentesis, and I'm going to show you lots of videos because I always do diagnostic paracentesis with a lung ultrasound if it's available. So, what I'd say is that where you keep your kind of log, there's a section underneath which basically has diagnostic procedures that you can see there. So that's a separate column. And if you're using a lung ultrasound to do a diagnostic procedure like a needle thoracentesis or a diagnostic paracentesis, then I would keep those images stored here. And they're very good examples of how you're using it in clinical practice.
Just Alok, please, but just one question to finish the logbook.
Yeah.
When you have the logbook, okay, we put all our cases on this logbook, and when we upload it, which website that you can see it and correct it?
You can choose any website that you want. There is Microsoft OneDrive, there's Dropbox, there is Amazon. The cheapest of all three of these are Amazon. The Amazon basically gives you a very, very large amount of data sets for a very small price. Dropbox gives you 2 GB free. I think it does. And Google Drive gives you up to 15 GB free. My only worry about Google Drive is the security around it on European servers. In that I have seen quite a few accounts where people are able to hack into it. So I just don't feel happy using Google Drive. But you can use any of these three. There are lots of other storage. You can have offline storage. So offline storage, if I give you an example.
And you can see it, Dr. Alok, you can see it?
Yeah, so if you share that with me, yes, I can see it. But for those of you, obviously, we have people who are working in countries where they can't afford this. You can store it on as a file in my Dropbox. What I would say is that once you're happy that you've finished and you've maintained, then I would say that you download that file and keep it with you.
So you should send us an invitation for your Dropbox, yes?
Yeah, my apologies. Have I not done that with you?
Okay, no.
I'm so sorry. I apologize. So I will do that.
Thank you very
So I will send it to you so that, and it's a good example. The reason I also do that is it's a good example for you to be able to peer review with each other, how you can maintain, because, you know, Dr. Anna, I mean, her logbook it's amazing. And it's a really good example of how you anonymize and keep things in a way that is legit, legal, easily interpretable for the person who's actually sharing the images, and easily, you know, what I'd say is credentialing can be done quite easily as well.
Thank you very much.
Okay, Jean, do you want to go for it?
Yes, I had a quick question about the file type we save.
My advice, my advice would be that your PowerPoint presentations with the history and the embedded MPEGs or MP4 files are saved as a PowerPoint. If you find, and this is where I would say that less is more, and that's why I was saying it's good to present maybe 1 or 2 cases, because if you do 5 cases with lots of videos, your file will be very large and it will crash. And so will your Microsoft Word document. So the way I've always done it is I've always saved each case, and if you see the logbook, as a single case with relevant videos of interest. And that basically means that it's the videos of interest that I usually save in that. Up to a certain point, if you're saving 1 or 2 cases with the videos embedded as Microsoft PowerPoint, it won't be a problem. Once your logbook becomes 100 cases, my logbook is about 168 cases at the moment, then things start becoming very bulky. So in that situation, what I'm doing now is I simply take the image that is relevant or the MPEG file that's relevant, anonymize it completely, and just embed it just as an object. It's single image. Does that help?
Okay, so yeah, so save the PowerPoint as a PDF with the movies embedded into the PowerPoint.
No. Use it as, and try to embed it as a PowerPoint. If you save it as a PDF, unless you're using, so I mean, try as a PDF. You can do it as a PDF as well. But when you're using it, if you're not using Adobe DC, I think you'll struggle to enable media. Have a go at both and let us know as well. But my experience is if you're just using plain Adobe, I don't think it will have the facility to play media.
Okay, thank you.
No problems. Dr. Rathore, one last question from you. Okay, I think Dr. Rathore might not have heard me. So I'm just going to stop screen sharing. What we're going to do is we're going to do a little bit of a workshop over the next, say, half an hour to 40 minutes. And really, from our perspective, what I'm basically going to talk to you today about is probably the most important aspect of lung ultrasound, and that is mental modeling. And it's very important that you stick to a structure that is there. Now I'm in trouble because I've got, I need to say. So can you see my screen?
Yes.
Yes.
Yeah.
Okay, lovely. So what we're doing today is we're having a little bit of an interactive workshop. Where possible, it would be nice if we can see your video. Obviously, if it's not reasonable, and I know that sometimes even I am not reasonable, but kind of while we're talking to you, it would be nice to be able to see your face if possible. But what I'm going to talk about at this particular point is a clinical radiological approach to performing lung ultrasound, which we are going to use throughout our practice over the coming weeks. So a lot of you are now using lung ultrasound. Your diagnostic kind of correlation is the next step, in that you're able to clearly identify artifact, A lines, B lines, total sliding, kind of profiles, A profile, B profile, A prime profile, B prime profile, C profile. You're also able to identify and image optimize. And I would say the 2 aspects there that we've focused on are kind of use of frequency to improve depth, especially if you're using frequency in the context of, say, a term baby, where you're not getting deeper kind of sections. You might want to reduce the frequency if you're using a higher frequency to get better depth penetration. So you're familiar with that. But really what we're going to do now is we're going to go through a concept of diagnostic mental modeling. And what that basically says is that you should be using a clinical approach when you are trying to make a diagnosis of what you think you are seeing on lung ultrasound. You should describe that after interpretation in a standardized way. And a standardized way for me kind of means it really starts with tissue from the top, superficial, ribs, the visibility of the bat sign, pleura, pleural sliding. When I talk about describing pleura, so just remember the protocol that we shared with you, which is kind of lung ultrasound step by step. And that basically says, is the pleura continuous? What is the appearance like? Is there sliding? Is there an element of subpleural consolidations of any kind? And then after that, really what we're talking about is whether we think the pleura is thick, irregular, and broken. So you're using objective terminology and kind of coming and saying, oh, the pleura looks abnormal. Abnormal has a very wide connotation. Now, the problem is when you think about it in a more objective way, you then are more likely to come to a more objective approach to making a diagnosis. But really, once you've kind of looked and described pleura, what you're then looking at is you're looking at the partitioning. And the partitioning means you are looking at each standard region. I think if you're using a hockey stick, you really need to do multiple rib spaces. And what you would be doing is longitudinal scanning as a start. But where you have an element of interest, like a consolidation, you'd be thinking of doing transverse scans in those intercostal spaces to try and further delineate those kind of images. And at the end of it, based on your kind of scan and whether it's appropriate to do the posterior regions in a supine baby, you'd make a diagnostic correlation in your mind to a diagnosis. You'd kind of think of, okay, this is what I'm thinking. And then after that, what you'd do is you would act on that. Now, you must be thinking, Dr. Sharma is really going through this in quite a lot of detail. What's his point? My point exactly is that what you don't want to do and what I see commonly and what I have done as a person in my more, I would say, formative years, and I'm still learning, is, oh, I look at R1 and I think R1, oh, there's a pneumothorax there. Yep. Okay, fine. But really what I should be doing is going a step back. I should be thinking about the bat sign, pleura, pleural sliding, what the pleura looks like, underlying lung, and then basically coming to the conclusion that actually there's an A prime or an A dash profile in R1. Well, actually, what is really important is that as I slide from R1 to R2 to R3, I am looking very well at trying to delineate a lung point, and then I'm putting M mode. Now, for visibility's sake, and we'll go through the cases today, you'll find it very interesting because pleural sliding is a very interesting concept. And we'll do a lot of cases today, but once you go through that process and you have done what I call a comprehensive scan, you are more able then not to miss things. But more importantly, what you might find is you think that this baby's got a pneumonia, and actually there's meconium at birth and this baby is about 12 hours old. And when you kind of look at the skin and the staining, so pneumonia and meconium aspiration are common differentials of each other. But if you start thinking of a mnemonic consolidation based on just looking at R1 and you haven't looked at the posterior regions, which is what me and Nadia discussed in the last, you really risk missing out. So that's just an introduction, but a very important aspect of the clinical approach to respiratory distress after birth is what we're going to discuss today. So what are the common reasons for respiratory distress after birth? So let's go step by step. So who wants to go for it? Common causes of respiratory distress after birth. Dr. Latif. Dr. Latif might be listening in. Funny, you want to go for the causes of respiratory distress? Yeah.
Yeah, Dr. Alok. So basically, if it is a term baby, usually we think of TTNB. If it is a preterm respiratory distress syndrome, and then if there are any features of leaking PV also, we'll think of congenital pneumonia.
Yep. Okay. So that's good. Any others? Anybody else want to comment?
Yes, we can add, for example, spontaneous pneumothorax.
Very good. Yeah.
Any congenital pleural effusion or tylothorax or any lung malformation.
Beautiful. So we've got so a few of the differentials that come up. So you have respiratory distress, pneumonia, meconium aspiration, sepsis. There's also delayed perinatal adaptation and pneumothorax. And we'll talk about TDNB and delayed perinatal adaptation because this is very important. We'll also talk about sepsis because a lot of babies who have underlying sepsis will be tachypneic. And really what we'll often find in them is a transitioning B profile. Now, the real question from our perspective is GBS pneumonia commonly often presents with a very similar kind of a B profile, which is transitioning, often with an elevated CRP without any fractal or shred sign at that stage. And you have to be very, very careful of really how you are clinically correlating. Now, the reason I keep TTNB in the middle is it's once you've excluded all these diagnoses that you'd come to a diagnosis of transient tachypnea newborn. And this is very, very important. And the reason I'm putting emphasis on this aspect of it is if you were to move to a stage where you decided, and I'm not saying that you will, and I'm still a very big fan of using chest X-ray, but in units like Nadia's and in China with Dr. Liu, they don't use chest X-rays at all. For them, the diagnosis of transient tachypnea is truly a diagnosis that is made by exclusion. It's made by doing comprehensive lung ultrasounds of every region. Because actually, when you look at a chest X-ray, more or less, you're looking at every region, but you might be missing out on the posterior regions. It's more difficult to see the retrocardiac shadows. And these are regions that can be interrogated by lung ultrasound. They can give you much more information on particular consolidations. But for them, doing a comprehensive scan is a very important aspect of making these diagnoses. And they use a very similar kind of a principle of mental modeling for clinical correlation. But the less common causes, we discuss CDH, lobar sequestration, lung agenesis, then the non-respiratory causes, central causes. You have babies who are tachypneic because there's something central going on. They might have congenital hydrocephalus. If a baby is meningitic, they'll have high drive. The SMAs will have no drive. They'll have severe recession if they're mild, but that's where you'll get a normal lung ultrasound. Obviously, if you intubated a baby with SMA, and a lot of these babies present floppy at birth and have significant respiratory distress for the spectrum, which is not so severe. So they end up with a tube. And it would not be unusual in units who are not doing chest X-rays for them to clinically correlate neurology, but to do a lung ultrasound and actually make a diagnosis which basically shows a normal lung. But a good example and how people can get confused is if your tube is down the right main bronchus and you pick up a right-sided collapse consolidation because of that, then the real question is if your CRP is normal and everything is normal and you pull the tube back and you repeat a lung ultrasound and it improves, then the problem here was not a pneumonia in this baby. It's not aspiration. It's mechanical collapse. And this is where your mental modeling, your clinical correlation, your description of exactly what you see now and what you see afterwards is very important. So with that in mind, what we are going to do today is, before I talk about the diagnosis, is go through a few cases. So first of all, what I'd like us to do is use the standard protocol for lung ultrasound. And really what we need to do is stick to the basics. So whenever you start scanning any preterm baby, use the probe and use your highest frequency possible. From my perspective, I like using a linear probe. I can achieve a high frequency with it and I can achieve much more in terms of the anatomy. But if you have a hockey stick, just remember you're going to get only 2 intercostal spaces. So make sure that you're interrogating all the areas that we're seeing. R1, R2 might need multiple images with the hockey stick in order for you to get the entire anatomy. But more importantly, when you choose your preset, make sure that or if you're using a non-preset mode, that you've got adequate depth, your focus is at the pleural line, and you're able to adjust frequency to be able to get the lung. Again, basics, just lung partitioning. Going forwards, for those of you who move towards L2 proficiency, you will be using the 6-region method. And the expectation from my perspective for any baby who's born at birth who has respiratory distress, as a bare minimum, is that you are doing longitudinal scanning of R1, R2, R3, R4, and R5, R6 through the posterior axillary line. If you do not want to move the baby, and this is something that Nadia touched upon, you can either tilt them slightly, and that means you won't get the entire posterior region. But what you can do, if this is the baby and the axilla, and if you're looking at me, is basically scanning with the probe through the posterior axillary line so that you can see the posterior part of the lung. And then if in that situation you feel you have not made a diagnosis based on some of the cases that we described today, then really what you need to be doing is transverse interrogation of the relevant intercostal spaces. And I think if you're kind of in a situation where you're worried about mnemonic consolidation or pneumonia, then I would suggest that you need to do comprehensive scans of all areas, because really you need to know exactly where mnemonic consolidation is. And posterior mnemonic consolidation is more common than anterior, especially if the baby's supine, because of the way exudate air actually settles. Okay, so Kirti's asked, do we wait 30 to 60 minutes before scanning posterior regions if we turn the baby? What I'd say is that actually, if I've got a baby who's supine, I will, if I want to do the posterior regions, try to get information, and I'm just going to show you my cursor, by scanning through the posterior axillary line first. If I still struggle, I will tilt the baby just a little bit like this, so not all the way on that left side, to try and access the baby on that side, and then tilt on the opposite side to get the posterior regions. I think if we think that it's crucial, you've got something that looks really odd, you've got a translobar consolidation, that will show up quite easily in the posterior axillary line simply by going through this. But for very small consolidations, really, if you see my cursor here, just below the level of the scapula, at that angle, we call that the Plapp's point. Really scanning in that area can actually diagnose posterior consolidations, mnemonic consolidations, especially for the babies who've got chronic lung disease or lungs, or a good example is if a baby aspirates. They usually aspirate down the right main bronchus. Now, those aspirations might be to the posterior part of the lung in supine position. So really, if you do the anterior and lateral, you get nothing. You still could have a posterior aspiration because aspiration tends to go to the back of the lung. So I would say that's really important that, if you're thinking mnemonic consolidation or consolidation secondary to aspiration, that you try to do the regions and handle the baby as minimally as possible, but doing the posterior lung fields either through the posterior axillary line or by tilting the baby as we've tilted over here.
Okay, thank you.
Now, once you've kind of done this, I'm going to have to stop my laser pointer. Really, what you want to then do is basically think about if you've got RDS, your lung ultrasound scores, and we as a standard will be using Bratt's method. I will be discussing when I cover respiratory distress syndrome, the posterior scores that Nadia has discussed again in a little bit more detail. And there is one posterior scoring method that I would recommend that you might want to use, which, some of our colleagues in Canada, in fact, Yasser's group likes to use the 12-region method. And I think, that is perfectly acceptable. And, whether it is more effective in diagnosis, I'm not sure. And there's certainly no evidence to say that you're better able to diagnose RDS by using a 12-region method of scoring as opposed to just using the anterior and lateral kind of regions to score the 3-region method on either side. So that is where I'm going to stop. And now we're going to go into a little bit of a workshop. So what we're going to do is I'm going to get Dr. Zaharuddin and I'm going to get Dr. Naz. So what we're going to do is, Naz, you're going to critique the L1 images, and I'm going to show you L1 images first, and then Dr. Zaharuddin will critique the R images, and we'll see. So the way we're working in this workshop is, I'm giving you the history, I'm giving you the images. I want you to use the protocol that I've just described. So you're starting right from the bat sign, pleura, describing the pleura, then describing the region, and describing what you can see. And then at the end, what I would say is you're going to come to a mental model of what you think is wrong on that side after having seen those images. Where you don't have an image, I will add in to say that it was similar in appearance to the other images. So you might have L1, L3, but I've omitted L2 because it was exactly the same as L1. So I'll let you know that. So I'm going to give you a case. So this is a term baby born at 40 weeks. This baby was basically delivered by emergency cesarean section for a little bit of fetal distress. The baby came out, didn't need much in terms of resuscitation, was kind of given PEEP for about 20 minutes. And really the expectation from the person reviewing the baby was that they'd come back and see the baby. And when they reviewed the baby at 2 hours of age, this baby was grunting quite significantly. So they admitted the baby to the neonatal unit. And by about 3 hours of age, I mean, this baby had partial screen antibiotics, was in 40% FiO2 on CPAP. And the first gas is a pH of 7.25 with a CO2 of 8 kilopascals, which kind of works out to be about 60 millimeter. Lactate is normal, and we started antibiotics. Do you have any other questions?
Sorry, there's no history of GBS or any risk factors in mum scans, otherwise good. Antenatal scans are fine.
Absolutely. Normal antenatal scans, no history of GBS, no history of PROM, a little bit of high blood pressure, but she kind of went into labor, and nobody even attended the delivery until the midwives said the baby was a little bit distressed. So had some PEEP, now is grunting. Ooh. So you're seeing the L1 and L3 images. So Naz, you're commenting on the L1, L3 images.
So the L1, so that will be left-sided anterior upper. So you can see 3 rib spaces. And it's a longitudinal scan, and you can see the bat sign. And you can see the pleura, you can see it sliding quite nicely everywhere. So I think it's pretty regular. Probably a few comet tails coming up on the right side of the screen, a few of them. And then you can see some A lines going down, and over here, and then some B lines coming up as well over there.
So when you critique this, what's wrong with the person doing the scan? Can he make this better?
The depth of it is 3 centimeters, but you can't see below kind of 1.5 centimeters such. So it'd be nice to get a little bit more depth.
Beautiful. Well done. So probably want to go up to about 4 to 5 centimeters on the depth. The frequency, obviously, from our perspective, I mean, I can tell you I'm using a frequency of 12 over here kind of means with focus at the pleural line that I've actually lost out on depth interpretation. But yeah, I agree. What about L3?
So L3 would be the left-sided upper lateral and the axillary region. So again, you can see the bat sign. You've got nice 3-4 spaces, in fact. You can see the lung sliding actually well. It seems a bit thicker actually on the left side, but otherwise it's quite clean and regular.
Why do you think it's thicker? What is the gentleman who's doing the scan doing? Can he make this image better?
Probably getting some nurse to calm the baby down might help, I think. Sometimes
so Naz is being very nice. So really, what the problem here is probe is not perpendicular. That's a big problem. Because we're in the upper part of the axilla, naturally, the axillary pad of fat basically comes in there. So getting a nurse to lift the arm. Again, coming back to that concept of us making sure that we are optimizing the baby for the scan. But yeah, I think I'd agree with you. So in terms of profiles, what do you think this is? And you can assume that all the other images, that's L2 to L6, was similar.
So it's mainly an A profile, but there's some B lines coming in over there. It looks more like an A profile, I would say. And I probably think it's a bit of transition rather than an RDS at this stage.
Okay, that's great. So that's beautiful. So now I'm going to get Dr. Zaruddin in. My apologies. Sorry, Naz. We have a few more images. So do you want to just go through? So that's L3. It's a little bit better with L3, you think, this time?
Yes, definitely. I think so. But that was L3 as well, which we saw, isn't it?
Yeah, but this time Dr. Sharma got the nurse to hold the baby and repeated the scan, and it's a little bit more perpendicular.
A little bit more perpendicular. Lovely bat signs coming up. Lots of rib spaces. Much clearer pleura, lung sliding seen really well. A few comet tails coming up, but mainly an A profile there.
And the M mode?
And the M mode shows a nice seashore appearance.
Yep. So a nice seashore appearance. You've got T lines that are coming up there, which basically reflect a little bit of the heart pulse. But yeah, nice seashore appearance. And it's a really good opportunity for us to see sliding. I see sliding really nicely. So when I look at the image, you can see sliding and all with, a dominant A profile at this particular point. So you've got a mental model. So now let's get Dr. Zaruddin to interpret the right lung. Dr. Zaruddin, would you like to talk to us about the right lung?
Yes, thanks. So R1, starting from top to bottom, really, I can see the, I can't see the ribs nicely stacked next to each other, but I can see a nice pleural line with probably slightly irregular towards the right side of the image in R1. But it's generally speaking, it's nice and regular with sliding. There is some comet tail artifacts and A lines as well on R1. The image is frozen now. I'm not sure if it can be made to be moved again.
Yeah. Okay, so very nice, very good. So just when you look at R1 and R2, so which of these is a transverse and which of these is a longitudinal scan?
I think the R1 on the right is a longitudinal one. Probably R1 on the left side of the slide is I think it's a transverse probably.
Beautiful, absolutely right. So let's just as you described. So when you look at R1, what do you think about pleural sliding and the pleura?
Let me just have a look. I think it's I'm a bit confused between the breathing movement and the pleural sliding as well.
Yep. Beautiful, absolutely beautiful. And what I'd say is that this is the opportunity for us to kind of discuss the intricacies of pleural sliding, and that it can be so subtle and so difficult. So just over here, do you think there's sliding here?
As I said, it's the breathing movement gives you the false impression of sliding, but maybe when I look at it in depth, I can't see much of a pleural sliding. It's actually the movement of the breaths is again the same movement of the pleura. There's no different movements that will give you the impression of sliding as such. So the pleural line is moving exactly the same direction of the breaths.
Okay. So one thing that really helps in situations like this is if you have beelines or comet tails and you can see them move and
Yeah.
lines move. So if you have beelines and comet tails that are moving in this kind of a pattern, you probably do have pleural sliding.
Okay.
What about here?
Here, there are some, perhaps there are some A lines as although they are not nicely parallel to each other as the way that I would like them to be, especially the A line, the first A line, it looks like oblique. Again, there are no comet tails at all that I can see. Not sure if there is a very vague B lines, but it's mainly horizontal A lines. But back to the main question, really, sliding is not as good as on the left side of the screen.
Very good.
So,
very good. So I think, the kind of, what are you thinking at the moment? Maybe with respiratory distress, deep for about 30 minutes, kind of 2 hours, CPAP, still grunting. So kind of
pneumothorax will jump to mind, of course, especially with the clinical picture and the use of CPAP, and as well as the sliding of the pleura that is missing on the right side of the screen.
So when you look at the right side, which is the longitudinal image, what do we see over here?
There is sliding up until the right side where your pointer is. That's when the B profile starts to appear, and there might be a lung point there.
Very nice, very nice. So beautiful. So okay, so we've clearly got anything else?
There is the truck sign, nice truck sign that you can see on either sides of the pleura.
Amazing. So clearly worries that there's an pneumothorax. And what do we need to do next? So next thing from our perspective is our M mode.
Yes.
Okay, so these are M modes, and this is the M mode of L1, and that's the M mode of R1. So any comments?
R1 obviously is showing a clear distinction between the two patterns of M mode that we have learned about, the seashore and the barcode, while on L1 the M mode appears to be again actually if I look carefully, but it looks pretty much, I'm not sure if there is a bit of just to the right of the pointer here, just if you move right, yes, exactly. Whether
and there's some areas that, and this is where I'd say to you, don't worry, don't try to interrogate that too much, because depending on how coarse in the movements of the baby, really what we want to see, and this is really important, and this is where I would say to you that if in your cases you are confused about sliding, so really what you want to do is you want to do your M mode over here and you want to do your M mode over here. And the reason you get a seashore sign is because of sliding of the visceral pleura over the parietal pleura. So what is happening is because you've got sliding of the visceral and the parietal pleura, you get this shimmering appearance. And all credit to Dr. Abhijit, he's taught me this terminology. So if he's here today, thank you very much. But clearly from my perspective, this shimmering gives you the classical pattern of what we call as the sand, the beach, and these are the waves. Whereas when you have air over there, the parietal and visceral pleura are separated so they can't slide. So now a simple thing that I want you to do before you scan next time is I want you to take your probe, I want you to put a little gel on it and just hang it up in the air and press M mode. And when you hang it up in the air and it's not in contact with anything, it will give you the barcode. It'll give you a beautiful barcode. What it basically means is that because there's air there that is reflecting everything back, there's nothing going into the deeper tissue, and you can't see sliding. There's no shimmering. But here we're at the lung point, and because we're at the lung point, you see what is classically a little bit of a seashore sign transitioning to a barcode sign. So this is kind of your lung point as it comes. And really, if you move your lung point from where there is sliding to where there's no sliding, then theoretically, from your perspective, you would be able to achieve a transition of the seashore to the barcode sign.
Well, thank you.
Yeah.
So I can understand from this. So the lesson to be learned here is, if you are in doubt of lung sliding, then your next step is obviously M mode.
M mode. And just a recommendation from my side.
He's way off. Oh, you can go.
Sorry, was that a question? Sorry. So I was just saying that my standard practice would be that when I'm doing my first lung ultrasound on every baby, and I'm doing the transverse and the longitudinal scanning, I do longitudinal, where I'm worried about a pneumothorax, and then if I find areas where there's a lung point, I'll then interrogate that area transversely as well, moving from the center of the chest out. Some people like to move from outside to in, but it is very important that if you're confused whether there's sliding or not in a small area, that you put the M mode on and interrogate that area. And I would do M modes for all those areas as my first scan. So what is your diagnosis? So let's let the Dr. Naz come in. Dr. Naz, do you agree with your colleague's findings? That is Dr. Zaruddin's findings?
Yes.
Okay. So what do you think you have here? Assuming that every other region. So let's see if I had the R2 images. Probably didn't actually, but I need to take the laser pointer off. So this is just, again, playing out. So you can see as I play them out, the transition of the lung point there. And here you've got a classical seashore sign. And it's more visible on this image, actually, better visible. So you can see the transition completely, where you transition into an area that is a barcode sign, seashore sign. And then basically what I've got is complete barcode. I've gone into the area. Can you see there's absolutely no pleural sliding there? So this is seashore sign, and you're transitioning, and this is all barcode here. So now you've moved from R1 to R3. So what kind of a pneumothorax do you think this is?
So it's probably a fairly big pneumothorax over here.
Okay, so if I were to say to your baby is in 30-35%, pulses are palpable, your CO2 is about 55, pH is 7.26, he's grunting. So this is where I'd say to you, you're right, there is quite a significant collection over here. But actually, from my perspective, the real question that I'm asking is, are we in a situation where we need to do anything about this clinically? So what would your clinical approach be now, but in your respective areas? So if I ask Dr. Zaruddin first, what if you were doing lung ultrasound where you currently worked, what do you think you'd do if you found this?
To be very, very honest, I'm going to do a chest X-ray.
Beautiful. Yeah, beautiful. That's exactly what I'd be doing over here as well. Naz, what would you be doing?
I'd be doing a chest X-ray, but I'll also be looking clinically what's happening to the baby as well.
Yeah. And really what I'd say to you is that actually the top half of R1 is not, it's normal. You have sliding there. There's an area between R1 and R3. So, in a baby that's clinically so stable, he's grunting, his FiO2 is only 30, saturating beautifully, no pre and post-ductal sats difference. Take my word for it, clinically, when we did the X-ray, what we had was just a very small anterior pneumothorax. And we conservatively managed this baby. So any questions about this? So first, Naz and Dr. Zaruddin, any questions?
So when we are looking at a pneumothorax, when we do the chest X-ray and we look clinically, as you said, clinically, this baby is relatively stable. Gases are pretty okay, saturating well. You'd leave this baby on CPAP and see how things go and progress.
No, I'd if I could, I'd put this baby
on Optiflow.
That would be my approach, but I mean, yeah.
And I guess some people might just put in a needle in and see. My question is that you, in the sense that let's say just the ultrasound show kind of like shift in mediastinum and other things, like if it's, those, would you be able to see that?
So very good. No, you won't. But the question that I would then ask you, for the purists who are just doing lung ultrasound, is clinically, if the baby is like that and you aim to either needle or you aim to manage conservatively, and I think the majority of people would manage this case conservatively, is my impression, until such time as the baby deteriorates. And what they would do is they would do trend analysis. And a trend analysis is you look at the baby over the next few hours to see whether it's deteriorating or getting better. And if it's deteriorating, they'd repeat a lung ultrasound. And if the pneumothorax was larger, then clinically they'd needle. The mediastinal shift in itself would not alter management significantly unless you find that there are other things clinically. I think clinically, if you're in a situation where this baby has weak pulses and or has severe respiratory distress, then you're making a diagnosis of a clinical kind of tension pneumothorax. And in that situation, the argument would be, well, most of those babies you'd needle even before getting a chest X-ray. So that is the argument that you'll get from the people who don't do an X-ray. I think my argument is that actually, why not use both if you have them? And the reason for that is, once you do a chest X-ray, we clearly have in our units where we work people who won't be using lung ultrasound. We need to be able to quantify this for them. And more importantly, I think trend analysis for them, because they will not be able to do lung ultrasound later on, might mean that they will be repeating an X-ray. So I think that's where there's slight differences in practice, which I would say are within an acceptable norm, where for a unit that doesn't do chest X-rays, that's acceptable. And for a unit that is starting to practice lung ultrasound, there's an acceptability to it. So Mayank has a question. Would you call it a large pneumothorax? No, I wouldn't. Because actually the upper half of R1, when I scanned it, actually has got lung sliding all the way. So really, I've got air, probably R1, R2, and a bit of R3 at this particular point. So there's an anterior kind of collection of air because this baby is supine. But if I look at the symptomatology as well, then theoretically, from my perspective, I would say that it doesn't fit with that. I'll show you the X-ray on the next class. I'm very happy to share it with you, which shows a very small anterior collection. Nothing that we did anything about. It was managed conservatively. And I'll be very honest to say to you, we never re-X-rayed this baby. After 24 hours, this baby was breastfeeding. So we have questions. So participants have raised their hands. Okay, go for it. Ask your questions. I think that's better.
Hi, thank you. So it is fair to say that when we perform the M mode, the A line tend to disappear?
No, the A lines are visible even when you do your M mode. So I'll take you back. Just give me a moment. So this is an M mode. So really, these are all A lines that are visible. There are no B lines at all. They look a little bit broken because of the way I'm holding my probe. It's a little bit oblique at this point when I'm doing the M mode. But in this section again, can you see how I can't see B lines? It's all A profile. So if I just take my laser pointer, problem is I can't play the image when I take my laser pointer. So these are A lines all the way down to the bottom. There are no B lines. A lines will always be present with a pneumothorax. You will never find B lines or comet tails. And there will be, so the 4 features of a pneumothorax are, we'll go back and I'll show that to you. So no pleural sliding, and this is the lung point coming in here. So which is why I'm saying that it's not the whole of R1 that's involved. Actually, you can clearly see B lines with lung sliding, and you have B lines coming in here. The reason they're not going all the way to the bottom is because I'm using a higher frequency. But what you've clearly got is a lung point where pleura is coming in, and then you have no pleural sliding with a complete A profile. So really, this is your lung point. But what you have to demonstrate in a pneumothorax is the absence of pleural sliding, a pure A-line A profile, A prime profile is what it's called because there's no pleural sliding, with a lung point. And then in that area, you have to be able to demonstrate a barcode sign. These are the mandatory things that you have to do. And you must always look for the lung point. And the reason I say that is, if you quantify the lung point as I have at the moment, and this baby deteriorates, and I come back a little later, and I actually go to the posterior axillary line for a baby who's supine. So if you look at me, I scan this region, this region, this region, and I had air up to the anterior axillary line. But now I've gone into the posterior axillary line and scanned. Well, this is getting worse. Any other questions?
So to quantify the pneumothorax, perhaps, as I understand, you will have to move up and down to, if you can, determine how many parts of, or how long the pleura has stopped sliding for. Is that correct?
Both. So you're absolutely right. And the reason, so if you were using a hockey stick and you put it here, it would only quantify 2 rib spaces and maybe 2 intercostal spaces. So that's R1. This is the left side. I'm so sorry, R1. This is also R1 above the nipple line. So really you have a pneumothorax over here, but it could extend all the way down here. So you'd have to look at R1, R2. And then really what I'd be doing is moving across, probably doing another region in the middle, moving across, and then basically doing R3, R4. And really that is quantifying all those areas, putting M mode on all of them, basically trying to look for a lung point. And as I move laterally and I find that actually now this air which is anterior has ceased, because I can actually see lung that is moving, because lung will collapse, but it will move. And at some point, what you'll see is an interface between heart and lung. And that interface between heart and lung, I will show you in the next talk on lung signs that we do. But really, that is the interface that is moving, that you see, which is what we call the lung point, in that the sliding happening over here, no sliding happening over there. So what you see is an action like this. So that is how you quantify the pneumothorax. You can have small pockets of air. If it was a very, very small pneumothorax, then you might just have a small pocket of air here, nothing below. So you actually have a lung point that finishes over here. But you must always see the lung point, which is the kind of transition point, because that is telling you that there is a normal part of lung as well, maybe collapsed, but coming into contact with the air pocket.
Very clear. Thank you.
Any other questions? One last question before we move on to the next case.
Yes, Alok. Can you hear me?
Yeah, I can hear you. Yeah.
If you are using the linear probe in a small baby, sometimes it's difficult to differentiate between the upper and lower. How you quantify it?
It's beautiful. It's beautiful. I would only use the linear probe if I could, because the linear probe will give you the entire area. And Leila, last case that I show you today will answer your question. So really, the advantages of using a linear probe to quantify a pneumothorax versus a hockey stick in a baby. So, okay, that's great. So we're going to move on to the next case. So we'll do one more. So this is case 2. So this was a baby whose mother went into spontaneous preterm labor. So what we're going to do is we're going to get Dr. Sharif and Dr. Doris. You will be critiquing these images. So let me see which side I offer first. I offer the right side first, and then I offer the left side. So Dr. Sharif, you can talk to me about the right-sided images, and then Dr. Doris can talk to me about the left-sided images. So the history is as the baby is preterm, 33 weeks. The reason the baby delivered is because the mother went into spontaneous preterm labor. There is no known risk factors. She did have a fall about 48 hours back, and then started with some Braxton Hicks contractions, and then went into quite precipitous labor. And the baby delivered. There was a little bit of kind of bleeding, which was mainly postpartum, nothing antepartum. The baby was born, had mild RDS, so actually was managed with PEEP and delivery suite, and actually recessed a little bit. Currently, this baby is about 3-4 hours of age. He's on CPAP in about 30%. He's had a partial screen, started antibiotic. The gases, basically, from our perspective, show a pH of 7.2 with a CO2 in the range of about 50. So the equivalent of about, again, 7.5 to 8 kilopascals. The lactate is 2.5. The baby is recessing, is working quite hard. So any questions? Baby's about 1,700 grams.
No, I believe you covered everything. Like the mom is not diabetic, not hypertensive. Baby has no steroids, preterm 33 weeks, no risk factors for infection, and the baby is 2 hours of age with a respiratory acidosis in the blood gas, and requiring FiO2 of 30%.
Normal antenatal scans, the anomaly scan at 20 weeks was fine.
Yeah.
Okay.
So I have no questions at this point.
Okay, so we'll go on to the next. So these are the images that I'm playing. So what you can assume is this is basically R1, R2, R3, and R4.
Sorry, where is R4?
This is R1.
Yeah.
This is R2.
Okay.
This is R3. And this is R4. So we can talk at this. I've got my cursor over. This is R1.
Okay. So in R1, I can see two intercostal spaces, 3 ribs I could see. When I comment about the pleura, it looks thin, continuous, it's sliding. I can't appreciate subpleural consolidation, maybe on the very left side of the the other side. There is areas that it could be subpleural consolidation, but it's not very obvious.
No, less than 5 millimeters,
Yeah, less than 5
obvious
millimeters.
at all. Yeah.
So I wouldn't say, I'd say it's smooth and regular. Some common tails I could see.
Yeah.
And in I can see A lines. It's mainly A lines in both sides. I can't appreciate 3 B lines in one intercostal space. So the one on the left side. However, on the right side of the slide, the other side, I could see some B lines, compact B lines there. So it's common A and B profile there. Going to
AB profile.
AB profile. Going to R2. So the pleura is I can't see too much sliding, to be honest, on this side, on the right side of the slide. Comparing to the way that the pleura sliding here compared to R1, R2, I can't see too much sliding. So, but at the same time, I can see some common B tails and B lines there, and A lines as well. So it's common AB profile.
Sure. So my question is, what would you do if you were worried that there is kind of A lines and no sliding? What would your next step be?
Well, I would do M mode.
Beautiful. So you're going to do M mode over here. So for all practical purposes, we did M mode here, and you got a classical seashore sign over here, and you did M mode over here, and you got a classical seashore sign over here. Both.
Oh, okay, that's fine. I would make sure, I'm now confirmed that there is no pneumothorax because of that sign. So in both R1 and R2, there is mixed AB profile, I believe.
Yeah.
Going to R3, which is upper lateral, I can see pleural slide. I could see also it's some. I believe there is a long point well, I can see some A lines on the right side of the slide, but on the left side, I can't appreciate A lines. So I got mainly B lines on the left side, but there is A lines on the right side. The pleura is sliding here, and I believe there is area of micro consolidation. Yes, here on this side.
Okay, so do you mean double lung point as opposed to lung point? Because lung point would imply there's a pneumothorax, whereas you've kind of got B lines all the way through, even with the A lines.
So with the A lines, I can see like a couple of A lines on the right side. Yes.
Yeah.
But I can't see more B lines on the left, on the other intercostal spaces. Like I can't see A lines on the other side. So it might be a lung point.
So a lung point would imply a pneumothorax. So are you worried about sliding over there?
No, I'm not worried about pneumothorax here.
Okay, so the terminology that you should use is double lung point.
Double lung point.
Yeah, because the risk is if you say lung point, the connotation lung point is used only when you do a pneumothorax.
Yes, so double lung point.
Yeah. So again, over here, I mean, do you think this is a double lung point? You know, you've got a kind of a B profile. So the reason I say is when the baby inspires, you get this A profile that's dominant, but when the baby expires, it collapses. So this could be a double lung point, do you think?
I don't think this is a double lung point, no.
Okay, fair, that's fine. Okay, and what about R4?
So R4, I can see the pleura is sliding, but however, on the right side, it's a bit irregular. And with small micro consolidations, subpleural consolidations, common B tails could be seen. I can see also there is A lines and B lines, so it's AB line profile.
Yep, very good. So, and I mean, for me, this looks like a classical DLP, double lung point, because you've got a B profile with an A profile. But pleura, can you see the comet tails? They slide. It's beautiful.
Yeah.
The pleura being irregular is because I've lost contact over here. So as you can see a nice rib over here, and then you see a little shadow over there. So it is, I mean, if you look at the pleura here, it's thin, it's visible, it's continuous. Again, the problem with the pleura as it's visualized, can you see when I get better alignment, the image moves to the now the pleura becomes thin and clear. And actually some people think that's a shed sign. It's not. It's artifact because my probe is not aligned at 90.
Okay.
So the pleura basically looks as if it's falling away. It's actually intact on top.
Yeah.
So, you know, so my question to you is like 33-weeker, kind of a precipitous kind of delivery with a mother who's been in short labor after a fall. What kind of diagnosis are you thinking of at this stage based on the right side of the lung?
I got like my preliminary diagnosis could be a TTN picture.
Beautiful. Very good.
Yeah.
Okay, that's fine. So now what we're going to do is we are going to get the lovely Doris to critique the left side.
Okay, so looking at the left side, I take it that it's L1, L2, L3, L4.
Yep. So this is L1.
Yeah.
This is L2. This is L3. Sorry, not the one. That's L4. And I'm going to apologize in advance that for some reason my images are not playing ball today, which is really disappointing. Okay, so I'm just starting the images. So that's L1.
Okay.
What do you think?
Okay, so starting with L1, I can appreciate the three ribs and the pleural spaces and
sorry, yeah, excuse me, sorry, yeah.
Okay, and then starting with the pleura, so I can see the pleura. It's not moving. Okay, I can see the pleura.
Yep.
I'm not sure I'll describe it as continuous because it's compared to the other side, it doesn't look as continuous. The right side doesn't look as continuous compared to the right side.
Completely agree. Yeah.
Sorry?
I completely agree.
Oh, okay.
And just in terms, yeah. So what about, do you think there's subpleural consolidations?
Yes, I was coming to that. I can see, yeah, especially on the right side, yeah, those dots. So I think I would say there's subpleural consolidation, but the pleura is sliding.
And profile?
The profile, coming to the profile, very few A lines, but mainly B lines.
Yeah.
Yeah, and so comet tails, but I can see B lines extending down all the way.
Yep.
I don't know why is there lots of contact because of this space in between?
Yeah, just over there, there's lots of contact. So,
yeah.
Dr. Sharma, this is a scan, probably one of my earliest scans when I was still learning. But I think even with this, I would agree that the pleura looks really irregular. There's subpleural consolidations that are visible at this particular point. And classically, as a person early in my scanning place, I was unable to get any lung in L2. I couldn't get the heart out of the way. But it was easier to go to L3. Now, L3 is relatively perpendicular, as you can see. 3 ribs. So this is a really good area to comment on the pleura. What do you think?
Yeah, the pleura certainly not continuous, and I can appreciate lots of subpleural consolidations.
Yeah.
And there is pleural sliding, lots of B lines. I think maybe very few A lines. So it's certainly a B profile. And I would say the B lines are compact. So it's certainly a B profile as L1. Then L4.
Yeah.
L4, the pleura seems more regular, but I can still see lots of comet tails. I don't know whether I'll describe that as some subpleural consolidation. Maybe you can see some dots underneath, or maybe those are comet tails. But there is pleural sliding, some B lines, but lots of, from A lines, but lots of B lines and comet tails. But it's not as compact. The B lines are not as compact as L1 and L3.
So a little bit better aerated in that region. So when the baby inspires, you can see the A kind of lines coming.
Yeah.
But, in terms of subpleural consolidations, just over there. So if I just get my cursor up.
Yeah, you can see that,
So just over there, you can see this is a comet tail. Definitely, that might be a subpleural consolidation. So what are you thinking about the diagnosis of the left side?
So on the left side, there are lots of B lines, the compact B lines, lots of them. So I think my first thought would be surfactant deficiency. RDS.
Yeah. Okay, so RDS. Okay, now let's open this up to the audience. So questions, please, because the right side, clearly from our perspective, might have TTN as a problem, but the left side has what more looks like RDS. So let's talk about this. This is the right side again. Anybody want to throw any?
Yes, Dr. Alok. So if we do the score of this ultrasound from the right side and left side, it should be not less than 6. So more probably this is RDS more than TTN.
Okay, I would be a little bit cautious about using lung ultrasound scores to make that differentiation. So the classical definition of RDS versus TTN. So TTN classically does not have subpleural consolidations, and a combination of abnormal pleural sliding, which we can clearly see, it's very abnormal. It's not reduced over here. You put M mode in all these areas, you'll get a seashore sign. Clearly, from our perspective at this particular point, there is evidence of subpleural consolidations on the left side. Now, what I would argue to you is that actually we all know that double lung points can present in babies who have RDS as well. And when you have CPAP, the right anterior areas of the lung tend to get better aerated as compared to the left lung. So what normal aeration and normal lung fluid clearance when you have transition It's usually the right and the left anterior areas that get better aerated. So this could just be RDS itself with a double lung point where you're having resolution and improvement on the right side, but the left side is still very bad, which is why the baby's struggling. So that is kind of the interpretation we made. But can you see the point I'm trying to make is the mental modeling is so crucial in this situation? Because clinically, when I look at this baby, he's got severe work of breathing on CPAP. His FiO2 is going up to 40%. So what did we do? So we did give this baby surfactant. But you can see the images here. We did Lisa on this baby. And actually, this baby clinically improved after Lisa. And I mean, on the chest X-ray, this baby had moderate RDS. I'm not going to show you chest X-rays today. I want you to mentally model based on the lung ultrasound appearances. Any comments from anybody?
Hello, sir.
Yeah.
So from my understanding, that double lung point is not exclusively for TTNB. Anything
Absolutely.
with interstitial fluid, irrespective of anything with interstitial fluid will present with double lung point. And here
Absolutely.
I feel more like RDS because the subpleural consolidations is not seen in TTNB. It is actually, if there is no subpleural consolidations with normal pleural line, and with double lung point, we'll go with TTNB. But there is subpleural consolidation. The TTNB itself actually is one of the rule out that feature is what I understand. And it's look more like RDS with pictures of TTNB because of the interstitial fluid.
Okay, so this is a beautiful, is this Subhash?
Yes, sir.
So this is a beautiful example. Do you see what mental modeling is? You're sharing your mental model of why you think that way. But what you're doing is you're describing the images and you're using the description of the images to come to a description which mentally models you to think about it in clinical context. And this is what I want you, this is the next stage of how you should be reporting. So before I show you the last case, in fact, I'll keep the next two cases for next time because we want to have a little bit of your cases as well. But yeah, we have 3 more very nice, beautiful cases. What I'd like to do is basically take you through modeling before finishing, is take you basically through this concept. So when you've done your protocol, description is very important. And description wise, what I'd say is what you really need to be doing is describing what you can see in a standardized way. And as I've said to you, some of you, when we showed you the first case, went immediately to query, is there a pneumothorax? And really, that's a step too far for me. Go back to, first of all, describing your right lung, your left lung, each region. And what you're looking at is the pleura, its integrity. Now, again, what I'd say is abnormal is a very vague term. So is it continuous? What is, and how does it appear? Is there sliding? Are there any breaks in the pleura? Are there subpleural consolidations? I mean, is there shred sign visible? Then after that, what you're really talking about is the deeper lung and its appearance, the kind of profiles that you have. But more importantly, each of these areas should, if you're doing this as your scan, have an M mode for them to either demonstrate usually what is the seashore sign. But if you're worried about a pneumothorax, then clearly from your perspective, what you'd be getting is the barcode sign. And then what you are describing is, again, you might get, you say it's a B profile, but a B profile could be compact B lines, severe AIS or white lung, versus maybe just 3 to 5 lines per lung field, which is mild. So really, I would then focus on a description of those areas, and then whether you see subpleural or you see deeper consolidations. And then a few other things like whether you see effusions, because effusions are linked with both RDS as well as TTN. Mayank, you have a question.
I have a question regarding the last case. So the images that you show was actually a kind of heterogeneous picture for me. So I was a little confused if I should label it as RDS going by the clinical condition. If I correlate clinical as well as ultrasound, so the baby is on FiO2 of 40%. And usually the babies who require surfactant, and this baby is definitely more than 30%, on more than 30%. So usually in such conditions you would definitely get a homogeneous disease, and if we go by a lung ultrasound score of more than 8 or so. So this was actually not fitting into RDS, not into TTN, but probably was the baby on antibiotics also?
Yeah, the baby was on antibiotics, but I don't have any shred sign, and the baby's CRP was 111. Cultures were negative. I have time, because clearly from our perspective, what I'd say to you is you're looking at the scan at one point of time. I have actually done this scan before, after, and we've basically done a serial images on this baby for 24 hours, where you can actually see improvement. So retrospectively, again, what I'd say to you is, let's not get too fixated on the absolute certainty of a diagnosis at this point, because really clinical course and serial lung ultrasound would be a much better way of you being able to make that diagnosis. And that is why I would say that mental modeling wise, you have to make a choice here about what you're going to do. Really, if this is, and we know that TTN and RDS can overlap, that let's say there is an element of RDS over here. Well, this baby would still benefit from surfactant based on how he is clinically if we think there's surfactant deficiency. And I would also argue, just be very careful of labeling RDS as purely, it's homogeneous based on the fact that you have surfactant deficiency as the main pathogenesis. But we all know that surfactant deficiency can vary from reasons of the lung. And really, what we also know is that supine babies, when you give them CPAP and PEEP, they recycle surfactant much better in the areas of lung that are actually well aerated. Whereas the collapsed and attenuated areas tend to, if they're not recruited, develop worse hyaline membrane disease. So as a disease entity, the X-ray appearance that we've traditionally had is homogeneous, ground glass with air bronchograms. But actually, we've altered that natural history by giving this baby CPAP. And a good example that I'd give you is when you give surfactant, you classically get a whiteout to start off with, but later on what you get is, if it's down the right side, you get differential appearance. But CPAP and the respiratory support you're giving is creating this heterogeneity because you've got well aerated areas of lung that are not so surfactant deficient as compared to other areas. Irrespective of how you might argue it, and I'm mental modeling it in my mind, giving this baby surfactant is not unreasonable. You would agree?
So definitely, I would also have given surfactant anyway, because the baby has crossed that threshold. So, but the diagnosis might, but I'm not so sure if I'll be okay with making the diagnosis on ultrasound as RDS.
Yeah, that's fair. And that's fair. And you know, what I'd say is I have the benefit of hindsight. We've given surfactant, babies improved, we've done serial scans. So you could continue keeping an open mind and saying, look, it could be both. I'm going to treat with surfactant. I'll carry on scanning. And this could be a retrospective diagnosis like HI.
Okay.
You need more information. You need more clinical profile.
Thank you.
Okay. Any other questions? So last slide before we move on to your peer review is this. And this is the expectation that we have with regards to your reporting. So you're reporting all the regions, you're reporting all these things, and you use a standard terminology that you develop in your unit of how you want to use it. But for all practical purposes, what I'd say is pleura being abnormal has a very wide connotation. I think you need to give a very nice description of what you think about the pleura. But for sliding, I mean, we use a plus minus sign. So the reason I'm showing you this is because we have where I work in Southampton, we have a completely paperless system, and we had to have logs like this in order to kind of fill in details. Otherwise, writing descriptions, typing them in, it'll take days for us to fill the ultrasound reports in. But this is just one example of how you can report. Any questions about mental modeling, description, diagnosis, and clinical correlation? Does anybody have any doubts?
Hello, sir.
Yeah.
Sir, regarding the Brad score method, like if we we know that if it is more than 8 or 9 to give for the surfactant, is that a standardized standardized definition that any Brad score more than 8 to give surfactant?
What I'd say is that the BRAT score basically showed, when they took the area under the curve, that the sensitivity and specificity for need for surfactant based on how many babies got treated was only done when the score was above 8. But I would advise a little bit of caution. There's some authors who are now coming up and saying that we should actually use a score of 10 and above in a setting where RDS is. So a good example that I'd give you from our perspective is that you've got a 33-weeker, say, for example, who's more likely to have TTN. Now, the risk is if you keep a lower BRAT score for babies like that, you might end up giving surfactant to a lot of babies with TTN. On the other hand, if I want to make that more patient-specific or individualized treatment, if I've got a baby who's 33 weeks, who's basically got subpleural consolidations, along with the baby being an infant of a diabetic mother with uncontrolled diabetes, well, that is, can you see how I'm clinically correlating? And actually, some people would argue that you use a BRAT score of 8 in that baby. It should be lower. So there are arguments to individualize it. There are arguments to use it in certain patient-specific populations. But roughly, I would say to you that scores in the range of 8 to 10 are what are used as cutoffs to give surfactant in babies under 32 weeks of gestation. And it really depends on what you agree in your unit is your protocol. I know that in Nadia's unit, they will do an early lung ultrasound at 1 hour of age. And if the BRAT score is above 8, they will give that baby surfactant. So I think what I'd say to you, it also depends on your patient population. We know a lot of babies who are very IUGR, who are stressed, some of them who might be septic, often will have, lung sparing effects that you see on chest x-ray. So they might actually have lower scores. But actually, a lot of these babies get quite sick and have surfactant inactivation later on. So I think there is still work that needs to be done to kind of take these patient groups specifically to try and tease them out so that we can individualize surfactant treatment. My own approach, I would say, is I would first like to establish, I think this is RDS in every baby, 22 to 32 weeks of gestation. And I think, and I know that our protocol in Cornish obviously doesn't allow that at the moment because we're not using lung ultrasound. But doing the scan before 2 hours of age is very, very important, because the risk is you're then missing the window, because there are a lot of babies who will have very high scores who will not have hit an FiO2 based on European consensus guidelines to say that they should be treated with surfactant. Now, if you wait 8 hours and that baby then hits 40-45%, surfactant is going to be less effective. It's more effective the earlier you give it. Also, the hyaline membrane disease gets more established. So surfactant inactivation and its efficacy is reduced. So that is the benefit of giving it. Just, I will be forwarding to you, and some of you might have already read the European guidelines have been released with an update. And clearly what they allude to is that lung ultrasound is a modality that can be used for treatment and quantification of need for surfactant in babies who are extremely preterm. Last question, guys, because we want some peer review as well. That's it. Okay, any last question? So I'll stop share. And what we're going to do today is we'll peer review. What time is it, guys?
(8:35).
Okay, so we've got about half an hour. So let's see how many cases we get through. So who's going to share first? I think it was Funny. Dr. Funny, are you still there? I can't see Dr. Funny at the moment. She might.
Hello.
Yeah, she's there. Yeah.
Dr. Alok. Yeah, sorry.
Would you like to share? Yeah, that's okay.
Yeah. I'll start sharing just a minute. Krishna.
Just while Funny's sharing, any questions from anybody?
Is my screen visible?
It is visible. Yeah. Very nice.
Thank
If you
you.
just go into slideshow mode.
Yeah, I'm just doing it. Yeah. So I'm audible and my screen is visible, right?
That's correct. Yeah.
Thank you. Thanks a lot. So I'm going to present two cases today. And first one, this is the ultrasound machine which we are using. The we use a Philips Epic 7C. And I don't have a lung preset, so I'm using a vascular venous preset. I'll be commenting on the pleural line, the lung sliding, A lines, B lines, and the pathology.
Sure.
This is baby A, a 33 weeker, 1.4 kg baby. I've done this scan on day 2 of life. A brief history: baby is born of elective LACS because mother had a prolonged history of rupture of membranes for 4 weeks with leaking. And baby was growth restricted because mother also had severe anemia.
Yep.
Was a breech, so elective LACS was done. Baby cried immediately after birth. Initially, first few hours was stable, was on room air, but started having worsening from 18 hours of life. Was started on CPAP 7/40, and then later within a short time, around 6 hours, got intubated by 24 hours of life. Also had hemodynamic compromise in form of shock, so was started on was given fluid bolus and also started on inotropic support. At the time of scanning, baby was on HFO with a MAP of 13, amplitude of 35, frequency of 10, and FiO2 of 40%. And was on a dopamine at 10 mics per kg per minute. Otherwise, hemodynamic stability has achieved.
Okay, let's have a look at your scans. Yeah.
So this is R1.
Very nice.
Here, the baby was on HFO mode of ventilation.
Yeah.
So I have used a gain of 63% with depth of 4 centimeters. I can see the subcutaneous tissue and then ribs. And I think I can see on the left hand side it is looking like a dense B lines with pleura is sharp, regular on the right side, but on the left side it is seeming a bit irregular. And on the left it is a sliding. I think I could not comment on the sliding, but probably on the right hand side there is no pleural sliding. And there's dense B profile on the left half of the screen, and on the
So
right of the screen it is.
Yeah, for me, Dr. Funny, I think there is sliding on that right side, and I know there's A lines, but you do have these comet tails that are moving. So do you want to highlight them? So just go, you've got these comet tails.
Yeah.
So they are definitely moving. So for me, it does appear that they're sliding on that side. And I would agree that the left side of your screen is a very dense B profile with, pleura that's a little bit irregular, subpleural consolidations. I mean, the question is whether you have one big consolidation there. So anyway, this is the right side, is it? R1.
Yeah, this is R1.
Okay. So that's fine. Where's your ET tube, just by the way? What level?
I'll show the ET also.
Okay, no problem.
In the next.
Okay, sure. Okay, yeah.
So this is R1 and R2, which captured in the same, like the probe is linear probe is a bigger one.
So that's fine. Let's move to the next one. Yeah.
This is R3 and R4.
Very nice.
I think I'm not very sure this is a good image because I don't see clear bat wings here.
Yeah, it's a little bit fuzzy. I think what you've basically got is you're using a linear probe, and the question from my perspective is, I'm just trying to work out the frequency. It's in the middle. Yeah. What frequency were you using?
So actually, I wanted to ask this doubt in my machine particularly. This is L12. It is the linear probe is L12.3. And I'm not very sure how to change the frequency because I've used this penetration gain in general and resolution, but it is showing some 38 hertz, 150 53 hertz and so. It's not coming in megahertz. So I'm confused.
Yeah, so my gut feeling is that's probably 3.8, which is why your image is so fuzzy. It's not as clear as
Okay.
it should
Okay.
be. So there will definitely be a kind of a button to basically alter your frequency. And really what you need to do is probably go to at least 10, and that'll give you a much better image. But roughly, again, you can see pleura. Question
Yeah.
is there a little bit of a pleural effusion there? You know, just there.
This one.
Yeah. I just wonder whether there's an
Yeah.
effusion there. But visible pleura at this particular point, which
Mm.
looks discrete with a kind of an A line that's visible underneath. And then there's this area again that looks quite consolidated in the upper half.
Yeah.
So,
Yeah.
and then you have liver below that.
Mm.
Yep. Okay.
Right.
So, yep. Carry on.
So coming to the next slide, next one. This is L1, L2. So I
Yep.
could not get the lung. It is I could just get the heart,
Yep.
and I was also a bit
So you're getting the aorta. You're getting the arch. It's a
yeah,
beautiful
yeah,
arch. Yeah.
yeah.
Yeah. An interrupted arch. No coarctation. Yeah. Yeah. Okay.
So I had a doubt of pneumomediastinum, but I didn't know
So
whether it would
pneumomediastinum
be
is not a diagnosis that we make on lung ultrasound.
okay. Okay,
I would
right.
just say that we're really talking about air in the pleura. We
Okay.
don't make a diagnosis of pneumomediastinum based on lung ultrasound at the moment. So yeah,
Sure,
basically
sure.
there's no lung that I could see in that view, but here I
Yeah.
can. Yep, this is very good. So this is
This
what
is
what?
actually I have done this with the help of my colleague. I'm not very sure what is the level.
Okay.
So no, sorry, this is L1 and L2. Like in the midline. This is just in the midline. I have just lateral to the sternum in L1 and L2. So
Sure.
here I'm able to see the ET. Do you want to comment on this?
So it's tricky for me because I would not normally look at the ET. In this, I would look at it with the aortic arch. So
Okay,
it's a
I
little bit
think in the
tricky.
next, okay, I think in the next
I
slide
mean,
I have
let's just
aortic arch.
focus on the lung. What do you think about the lung?
The lung is consolidated, like the pleural line is thick. There is probably some shred sign here, and then there are dense B lines.
So it's a B profile. I wouldn't be able to comment on the shred sign. Is this a moving image?
Yeah.
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 Again, I'd be a little bit wary of saying that shred sign. That's more like a subpleural consolidation, maybe a little bit of atelectasis where the lung has dropped back.
Okay.
For shred sign, it should be really irregular. We'll be covering pneumonia later on this week, and we'll show you the images.
Right.
But yeah. Yep.
Right. Okay. And I think this is the one which I tried to see the like how much distant is it from the RPA.
Yeah. So
The
basically, you've got the arch coming through there. This is the descending aorta. And my gut feeling is your ET is low because it's hitting the arch. So my view would be that better than looking at it on lung ultrasound, it's using the linear probe. It's better to kind of look at it using the cardiac probe. But yeah, the first thing that comes to mind when I look, my question is whether your tube might be low. So
yeah.
Yep.
Okay. Okay. Thank you.
Yeah.
So this is the X-ray of the baby.
Okay. I mean, what you've clearly got is that right-sided kind of collapse. You know, the question from your perspective is whether that's thymus or collapse, but you definitely have atelectasis of that right upper lobe. And then you've got quite significant consolidation of the right lower lobes. Yeah.
And I think there might be pleural effusion also because here the costophrenic angle is
and it's kind of what
blunted.
we saw. So yep. What I'd say is, Dr. Funny, really important for your labeling to be right. Yeah. And I would probably agree with Dr. Zaredin. Once your ET has been pulled back a little bit, you could go up on the map. But yeah, that's for me, when I critique your scans, few things that are very, very important. So just if you go back to slide 5, please.
Yeah.
So if we could, that's where your ultrasound starts. And if we just go, so again, what I'd say is that really the frequency that you're using is compromising the quality of your images. You've got good depth. The good thing is you can see the tissue all the way down to the bottom. But again, my slight kind of worry at this particular point is it's just the labeling. Where exactly are we with R1 at this particular point? Is this R1? And I would probably say your focus is okay. So your focus is decent. So the gain settings are also appropriate. So mainly it's the frequency. It's working with the frequency to get your images.
I'm not able to find out how to change frequency. I think.
Can you get your technician to come in? Yeah.
No, I think I'll call and I'll get some help.
Yeah. No problems. Okay.
Thank you.
My pleasure. So the next person is Mayank. Mayank, do you want to go for it?
I think I have one more scan. Dr. Alok,
should we do it next time, Funny, just so that we can get everybody to present? That would be really kind, because we've got Dr. Hasoon as well.
Sure.
Yeah.
Sure. Thank you. I'll stop sharing.
So, is my screen visible? So I have put the...
yeah, now it is. Yeah.
Okay, so I'll put it in slide mode.
Yeah.
I'll start with the case. So this baby was referred to us on day 2 of life for respiratory distress. The baby was born at 40 plus 3 weeks of gestation. Birth weight was 3.5 kg, and the baby was born through LSCS in view of meconium stain liquor. So the diagnosis that this baby had was vigorous MSL, meconium aspiration syndrome, PPHN, had left pneumothorax as well, and underwent ICD insertion. Baby also had shock, which was managed with inotropes. So currently the baby was around 88 hours of life, and fairly on minimal settings with PIP of 16, PEEP of 6, FiO2 of 30%, and the baby was comfortable. The rates were 40 to 50 per minute. There were no retractions, and there was an left ICD tube in situ.
So, let's have a look at your images.
Yeah. So I couldn't image the left lateral region because there was a dressing of the ICD. So first looking at the right lung. So these are the R1, R2 and right lateral images. Going systematically, I can see mostly one rib space clearly, and a little bit of second one. There are some, the pleura is looking normal and sliding well. There are multiple A lines, and I can see a few lung rockets. So in between, I can also appreciate some B lines, which is erasing the A lines. But the overall profile, I would like to label it as A profile. Similarly, in R2, I would label it as A profile. The pleura is normal, sliding well. There are A lines, there are some lung rockets, but this is predominantly an A profile. Again, the same I would say for the right lateral part of the lung. So if I move to the left lung, so this was interesting. So in L1, the pleura is nicely seen. There are no comet tails, there's no B lines, and the pleura is not sliding. So this is a prime profile or A dash profile. And when I came to the L2 region, I could see in the cranial part, I could appreciate the pleura, which was not sliding, and a complete A prime profile. And there was a lung point, and thereafter I could appreciate the sliding pleura, along with some lung rockets.
Beautiful.
This is probably the harsh shadow which is coming in this, because I'm in L2 region.
Yeah.
And when I put the M mode, I could appreciate in
Very
L1
nice.
and the,
Beautiful.
so
Yeah.
I could appreciate the barcode sign, and when I put the cursor on M mode in the lower part, and there were other images as well. I took the those images as well, so I could appreciate a seesaw shine in the part where the pleura was moving. So
Very nice. Yeah, it's
this
beautiful. Having a look at your images, very good quality, very good depth. I can interpret tissue all the way down to the bottom. Just do you have which machine are you using?
Sonosite H2.
Okay. Do you have sharp mode on that?
No, no, no. We do not have a focus point. We do not have a sharp
No,
mode.
the focus point you won't have because the machine, it's beautiful. It's organized in such a way that it optimizes ultrasound waves coming back. That sometimes does reduce artifact, but yeah, they're good. They're good images. I wouldn't critique them because a lot of kind of machines don't have sharp mode, and that just improves the crispness and quality of your images. What kind and how large do you think this pneumothorax is?
Because I could appreciate only on the anterior part, and I got the lung point on the anterior region. So I was thinking of it to be a very small pneumothorax.
Sure, that's fine.
Okay. But when so this was my interpretation. So an X-ray was already done 10 hours prior, but I didn't have a look at that X-ray. I wanted to blind myself before I did the ultrasound. So on my interpretation on ultrasound was left-sided pneumothorax, while well-aerated lung on the right side. But the X-ray, when I saw, then it was quite different from what I expected. So there were multiple infiltrates on both the sides, and I could not appreciate any kind of pneumothorax. This left ICD, which is in situ, but I could not appreciate any pneumothorax on the left side.
I would disagree, actually. I just wonder, if you look at that area there, I can't get my cursor. Just come down to the heart border.
Okay.
Come down to the heart border. Just there. That area of lucency. That to me looks like a small, margin of air, which is probably in the mediastinum. Then whether you have a little bit of an anterior air collection with it, because it's a very small pneumothorax, what you can see. Now, what I'd say to you, this is a very, very good case to talk about with meconium aspiration. So just remember that with early meconium aspiration, what happens with the clinical course is that you have a lot of mixed features of consolidation, atelectasis, because you have meconium plugging. Once you intubate and ventilate the baby, and in the healing phase, the young you get a lot of air trapping, even in the areas that you look at. And the one thing that I would genuinely comment on is that, your sliding could have been better on the right side if you look at it.
Okay.
So yeah, my gut feeling is what you're looking at this particular point is you're looking at a dominant A profile. I mean, this bit here, R1, right in the middle, that's quite a giant B line. The question is whether that is really a consolidation that you see. But the rest of the profiles that you actually see, again, I would say look reasonably okay, like an A profile, and probably just reflect air trapping. But just with R1, the center, that central kind of B line and that profile that you see there, I just wonder whether there's an element of consolidation there as opposed to this just being, it's quite dense in the middle. And again, if you went, and this is the challenge with the hockey stick, is that as you go lower down, right to the margin of your screen on R1, it looks very dense over there as well. And if you had a linear probe, do you have a linear probe, Mayank?
Yeah.
Can you, what I would advise is next time take these images and take them with the linear probe and take the longitudinal view. And actually that will give you a much better, what I call is a geographical view of the entire lung. I'm going to share 2 cases with you next time to show you the differences.
I did this
Yeah.
examination with a linear probe, and I had kept a depth of around 5 centimeters. So I also have now a query. So can we see if we have air trapping like in meconium aspiration we have? So can we see such good aerated lungs, but the X-ray picture would probably look like this?
It'll look like an A profile. But
Okay.
my experience, and it's not been described in the literature, is pleural sliding is not so good when you're air trapped. And
Okay.
a very good example is when you're oscillated and air trapped. So
Hmm.
sometimes it's to the point where you're worried, do you have a pneumothorax or not? So, but yeah, I mean, I'd agree over here that especially R1, that area in the middle, that is very suspicious. And again, just right side at the bottom, extreme screen, just it goes out. No, higher up when you come to the pleural line. There, if you just go all the way to the bottom, so in the
Okay.
expiration, the baby's basically collapsing down a little bit.
Hmm.
But I would agree that R2 and the right lateral look absolutely fine. So it's well aerated lung. You probably have those areas of lung that are better aerated as compared to R1. And that reflects in your X-ray. The interstitial appearance is probably right upper lobe. Just L2, the question that people were asking was, is that collapse consolidation in L2? That's heart.
For this? Okay,
Yeah.
so because I did the ultrasound, I know this is heart.
Yeah, this is heart. So just so that people don't get confused. But beautiful images, absolutely beautiful. Yeah. And
That's it from me.
Lovely. That's very kind. So yes, absolutely, Dr. Zaridin. That is the marker of improvement, is that you should be able to see once an air leak is completely resolved. You might, if you've put a chest drain in and the lung is fibrosed in an area, see lung sliding that is diminished or that is less than you would see in other lung that is normal. But otherwise, clinically, my perspective, I would say that you should be able to see lung sliding. So we're going to get Dr. Hassoun to share his images.
Thank you. Am I visible or audible?
You're visible and audible, sir. Thank you so much.
Thank you.
Dr. Hassoun, could you just introduce yourself to everybody? We'd be so grateful.
I'm Mohammed Hassoun, consultant neonatology, and I'm working now in Kuwait in Royal Bahrain Hospital in level 3 unit. And excuse me for this image, but this is my first lung ultrasound. So first case is late preterm, 36 week, C-section delivery, GBS negative mother, good ABGAR, no resuscitation needed, admission for persistent respiratory distress, IV perfusion and antibiotic started, and of course sepsis workup is taken, and this baby is on BiPAP, FiO 2.35 to 0.4, and with MAP 6 to 7. Chest X-ray, I will start this one by chest X-ray because this is my first ultrasound, and this chest X-ray was done before we did the ultrasound. And it was at almost between 6 and 9 hours, and we needed to know what is this. This is pneumonia or just TTN or RDS. So when we did the X-ray, it looked like pneumonia with this hazy lungs on the left and hazy lungs also on the right middle lobe. So at that time, at 9 hours of life, the baby was on BiPAP, FiO 2.35 with some tachypnea and minimum recession, with no improvement on BiPAP.
So what age was the X-ray? This
one is 4 to 6 hours, and ultrasound was by 8 hours.
Okay, that's fine. Thank you.
So you are welcome. I will start by L1, by order L1, L2. So this is L1. This is a Siemens ultrasound with linear probe, 12 hertz, and with depth of 4 centimeter. So on R1, we saw pleura is sliding. It looks regular, smooth, mostly A profile, and we have some B line in the lower part. This is R1.
Yep.
I don't know if we have Dr. Alok any comment, any criticizing, just do it because this is my first ultrasound. Just I needed your input also.
Yeah, very nice images. You've got a beautiful machine, can I say? Again, it shows a very nice, crisp pleura. And clearly what you can see is some comet tails with an A profile. You can then see what is a B profile in the kind of right side of the screen, classically what you describe as a double lung point. So your depth is up to 4. I'm just, your frequency is about 13. This is a term baby, isn't it?
Yes, term baby.
So just to get depth, to get the whole depth, my advice to everybody here when you're doing your lung ultrasounds is you can take an image like this, and then you can reduce your frequency to maybe about 10. And that basically ensures that you get better delineation of the lower half of the screen, which is kind of after 3 centimeters, because you're missing out after 3 centimeters. The last centimeter or so is just a black dark area. And really the risk is you might miss a consolidation. But I mean, the rest of the image is beautiful. You have mirror imaging of the ribs. Would you like to show everybody mirror imaging of the ribs? Now, obviously, this is not a sign that is pathognomonic of a pneumothorax. And then my only question is whether you have a little effusion there, small amount of fluid.
Here.
So yeah, just that black. Yeah, perfect. No, just above. Yeah.
Okay. Yeah.
There, yeah, you've got fluid there. So beautiful, very nice image. My only comment would be just reducing the frequency to get depth. The other option, obviously, from our perspective is you can drop the focus down to a slightly deeper level to delineate those areas. So reduce frequency and you can drop your focus to see the deeper areas a little bit better.
Thank you very much. So for me, this is R1 was double lung point.
Very good. Yeah, I would agree. And this sliding there, you can see comet tails all the way. Some of you might think, well, you have mirror imaging of the ribs. Is that a pneumothorax? It's not, because you see comet tails very nicely. If you have comet tails, and comet tails are a good marker that the pleura is sliding. So again, something that, Dr. Abhijit has kind of spoken about in previous lectures. Yep. Let's have a look at your next image. Yeah.
Okay. So this is R2. Here also the pleura is sliding and smooth, regular. There is comet tail sign and some B line in the lower part with also double lung point.
Yeah, very good. So you clearly, the baby's quite upset, so you've lost contact in the initial half of the image, but then you get a beautiful image with the right half of the screen showing what I would say is a kind of an AIS whiteout Coaley's B lines kind of a pattern. The upper half of the image shows an A profile with B lines and comet tails predominantly. So, yep, I would agree. Another double lung point. Very good. Yep.
Yeah. So this is lateral R3. Also, normal pleural sliding. Pleura is regular, smooth, comet tail sign, and I think complete white out lungs at the right side of the image. No.
Beautiful. It's an absolutely beautiful image. Dr. Hassoun, can I ask you for a favor?
Yeah.
So if you would be happy and if you can consent the parents, this would be a beautiful kind of a double lung point. I don't think I have an image like this in my collection, but yeah. And if they're happy, then, if they're happy and you could lend it to me for teaching purposes, I will acknowledge you. But if they're not, obviously.
With pleasure. With pleasure.
Yeah.
I would send
so can I just say, I'm just going to critique this is the bat sign is beautiful. I don't think I can do a better image than this. You've got complete because this is a term baby, the ribs are really nice and ossified. You've got this dark area of kind of dropout behind the ribs. And then you've got this pleura, which is there right in the center. Now, what I don't want you to get confused about, this is for my colleagues who are watching. So some people sometimes label that area just below the pleura with the B profile as subpleural consolidations. They're not, they're less than 5 millimeters. This is seen in TTN. So just above, just below the pleura. So if you go to the so those aren't subpleural consolidations. That's, they're kind of micro kind of consolidations, which less than 5.
This is my question. This is my question, because I was confused because I saw this micro consolidation or subpleural. So I thought maybe it's RDS more than TTN, but how come double lung point with a spared area and this subpleural consolidation?
And this is what I want to say to everybody, that when you have TTN, the pleura being regular, symmetrical, with sliding, can have an appearance of sometimes what we label as micro consolidations, but they're classically less than 5 millimeters. So these would not be labeled technically as significant subpleural consolidations as you see in RDS. And really what they are is they're just reflecting the fact that you have well aerated lung. So when this baby inspires, they actually disappear. When the baby expires, they come back. Whereas with subpleural consolidations, there's atelectasis and subpleural consolidation throughout. So, you know, beautiful images. I have nothing else to say. Again, the depth, as you can see. So your focus just could move up a notch just to be at the pleural line. And then if you want to see the deeper area of the lung, you can reduce your frequency and you can put the focus down a little bit. So it'll be interesting, like when you do your next scan, to kind of see how, for me, you improve on the deeper sections of the images.
Okay, thank you. Yeah. Thank you very much. So we will move to the left side. L1. Also L1, there is the normal sliding and the pleura is normal. For me, smooth, some comet tails and a grossly A profile.
Yep, very nice. Yep.
And the L2, yes, the same issue. Yani, pleural is sliding, good sliding, smooth, regular, and comet tails with mainly A profile.
Very good. So yeah. You have a little bit of lung pulse that's coming in there on that slide. But again, I can see comet tails, which would say to me that there is sliding there. It's not as good. And I think the reason the sliding is not as good is because you're not as perpendicular. So if you compare your image on the left, where you're completely perpendicular and you can see the pleural sliding, the pleural sliding is not as well visible over here as is seen because you're not exactly perpendicular to the image, and that is also why your ribs appear crowded there.
This is most difficult because left side with the heart, I couldn't do it like barely like this.
Yeah, what I'd suggest is that a good way of doing that in that situation is it's moving laterally, and you have to kind of angulate your probe. So if you look at my chest, you're kind of doing L1, and really sometimes you have to move medially and direct medially to get the heart out of the way. But when you come to this portion, this is where you get the most difficulty because the heart comes in. And really you have to move laterally. So you're kind of like, you use the posterior axillary line for the posterior images in the supine position. You might just have to use the anterior axillary line to have a look at the anterior part of the lung.
Okay. Thank you very much.
But yeah, very nice.
We will move now to, I think, the L3, this one. On L3 also, we have good pleural sliding and the smooth, the regular. And of the upper part, there is B line and lower part A line with some comet tail. And this also micro subpleural consolidation also was confusing me. But it's a double lung point, I think. No?
Yeah, it is a double lung point and they're very small. They're very, very small. Again, and this is where I would say that, look, if you are confused, the clinical course and serial lung ultrasounds will help.
Okay.
But they are now well described in the literature by Dr. Leo. And what he says is that they are usually less than 5 millimeters and that the profile still correlates with transient tachypnea, if that is
this
the case.
Baby, we didn't intubate. And we waited a few more hours, and after a few hours, baby FiO2 was decreased to 0.21, and the pressure decreased to C4, and then the second day, baby was on room air.
Amazing. Well done, sir. My compliments. And your depth here again, it's much better. Clearly, when you have a B profile, because you have interstitial fluid, which is going to reflect sound waves much better than aerated lung, you get much better visibility. But what we lose out on is the aerated part of the lung. So again, what I'd say is just trying to drop frequency a bit, playing around with it, and just moving the level of your focus down would help optimize the image for depth. That's the answer to the question that has been asked by one of my colleagues.
Thank you very much.
My pleasure. Thank you.
Should I go for the case too, or no time for it?
So, because I would like Dr. Zaruddin to present his case, we have 3 sessions this week. We'll have a lot of sessions, so please don't worry.
No problem.
Please don't.
Thank you.
That's so kind of you. I'm so grateful.
Okay,
Dr. Zaruddin. God bless you. Very nice.
Thank you very much. Interesting cases tonight.
Yeah, very interesting cases. I mean, we learned so much from this. Yeah, please carry on. Yeah.
Thank you. My case is basically a late preterm, 36-weeker plus 5 days, almost term, infant diabetic mother with a birth weight of 4.650. Presented with initial signs of respiratory distress. He was put on high flow nasal cannula, 6 liters per minute, with an FiO2 about 28%. Lung ultrasound actually was done on day 3 after the signs of respiratory distress have almost disappeared, and it is done just after the high flow was discontinued. So this is our one picture. As a reminder, our machine is a Sonosite with a preset lung settings. So, and I'm using the hockey stick probe.
Yep.
So as I can tell, there's obviously, given the size of the baby, a classical IDM that I haven't really seen for a while in terms of presentation clinically, but you can see how thick the subcutaneous tissues are. Then there is pleural sliding with still borderline tachypnea at times, given the breathing rate, and there is some comet tails coming up. The pleural line is almost regular. There is a B profile or B pattern, B line, sorry, on the left side of the screen, while A profile on the left side, on the right side of the screen.
Yep.
Then moving on to R2. R2 has again the regular pleural line with comet tail artifacts and lines, and predominantly an A profile with A lines could be seen. The depth is obviously 4.5 centimeter. Can I go back next to the...
Yep, looks like an A profile. That's very nice. And I mean, pleural sliding looks visible everywhere. Ribs are equidistant. The only thing I'd say about your previous image is the ribs a little bit crowded there. You know, those two ribs close together with quite a dense area, you know, in the middle of that kind of looks more than just a compact B line. Question is whether there's an element of consolidation, maybe atelectasis there. But yeah, it'll be interesting to kind of see what you think. Let's carry on. Yeah.
Then I'm just going to move to the next. That's R3.
Very nice. Yeah.
Again, you can see skin, subcutaneous tissues, and then ribs, acoustic shadowing, pleural line, again with comet tails and A profile.
Yeah, I would agree. So, you know, just a single B line that goes in the middle of the screen, but it looks like an A profile predominantly. Yep, less than 3 B lines per intercostal space. Good pleural sliding throughout. And I mean, you're getting good, reasonable, you know, even with your preset settings, I can interpret the deeper area of the lung. My only question is, do you know what frequency you're using for this baby?
It's actually, it's a preset frequency. I think there is
my suggestion is on the Sonosite, there is a button that you can press in your preset to change the frequency. Often it's, and it's worth getting your tech in just to see if he can set it that way, set it up, because you can change the frequency on the Sonosite. And the advantage with that is your depth, your visibility will be much better. The beauty of the Sonosite is you don't need to alter the focus because it basically takes pixels and optimizes them for every region. So just changing the frequency, maybe dropping it a little bit from where it is, will actually enable a little bit better kind of depth architecture interpretation. But yeah, for me clinically, and the image is beautiful. Yeah.
Okay. Moving down to R4, B lines are coming into the picture with some A lines of exhalation. The baby, as I said, it's 4.6 kilos, but with the help of my nurse, we were able to turn him around.
Well done.
It was a struggle, but it was. So this is the R5. You can see it's amazing how thick the subcutaneous tissue is.
Yeah, and it's a very nice image, sir. I'd say that the back regions in those big babies, you're perpendicular, you've got equidistant ribs, the pleural line is good, it's visible, it's, sharp and discrete. Obviously, the challenge here is you've got a lot of tissue through which lung ultrasound waves have to move. And my gut feeling is you've got a higher frequency, which means that the superficial areas of the lung are visible, but the deeper areas, a little bit of difficulty with visualizing them. There will be a triangle, and I can't see that there is a triangle, which goes between penetration, depth, and really helps with optimizing images. And it is something that you might want to just ask those guys to try and get up on your screen if you don't have it.
Yeah.
But carry on. Yeah. But it's a very nice image. Yeah.
And this is R6. Again, the posterior images, they don't seem to have much of a B profile on them.
How long after? Did you do them immediately or?
Actually, because obviously, given the size of the baby, what I did, I did the right and left anterior, and then we turned him around to do the posterior together. Obviously.
Sure.
But it was, to be honest, it was all, probably minutes difference. It's not, I didn't wait for long.
Yeah.
Just going to move to the left quickly, left side.
Yeah, sure.
This is the L1.
Very nice. Yeah, very nice.
Pleural sliding, comet tails, good pleural line, clear, and there is predominantly A profile.
Yeah.
L2, pretty much a similar picture.
Yeah. Gain settings could also go up just marginally, just playing with the gain a little bit.
Yeah.
We could go up marginally from where they are, but otherwise good. I can see tissue all the way down to L1 and L2 as well. Dominant A profiles, good pleural sliding, very good perpendicular probe positioning, very good. For such a big baby, my compliments. I just, for the group to learn that you're really probably using your nursing colleague and sucrose very well. So my compliments. Yep.
You just have to speak nicely to the nurses and you will get the... So this is L3.
Very nice. Beautiful. Yeah. Beautiful images.
And then L4. And then the posterior picture. I think this is, baby was really kind of moving a lot.
Yeah. Completely. And you've probably done the right side first. And then when you hit the left side, it becomes more challenging. So, yeah, completely. And it's to say to all colleagues who are doing the back, just it has a lot of proprioceptors. So often it is very difficult. The baby tends to arch quite a bit. And, it is really challenging. But your L6 image, again, it's pretty decent. Again, here I'd probably say you have more of a B profile, L6. So the pleural looks, but for me, I think you've got a lot of B lines there. And the only reason I'm 100% sure that if you were able to change your frequency a little bit, you'd be able to see those B lines hit right to the bottom.
Yeah, will do.
So they break the A lines. So, looks like a baby who's transitioning well, actually, clinically.
Yeah.
The only question that I have is whether you might have a little bit of consolidation in that R1 image that we saw, but that's about it. And sometimes once you've removed a little bit of pressure, you can have these areas of collapse consolidation that you find. And I mean, they're just a reflection of the fact that the baby's just lost a little bit of PEEP. Yep. That looks like a really nice barcode sign. Yep.
And then finally, this is his chest X-ray on admission, by the way.
Yep.
And that is him. Lovely, chubby.
Beautiful.
Thank you.
Very nice. So transitioning lung.
Say barcode sign on the M mode.
No. It's a seashore sign.
Yeah. Okay. Yeah.
Did I say barcode? I apologize if I did.
No. Sorry. Yeah. No problem.
No. It's a seashore sign. It's classical seashore sign. You can't see a barcode at all. Yeah.
Thank you very much. Thanks.
I am grateful, everybody. I am going to stop there just because I think it's been a long session, but really what we will be doing with the next session is showing you 3 more very interesting cases. And a lot of the focus this week is on the different types of pathology. So in the next session, we will be discussing air leaks. And in particular, some of the air leaks will kind of involve term and preterm babies, but we'll be going back to lung ultrasound, air leak, quantification of pneumothorax, management, and a little bit about how you can use lung ultrasound when you're draining an air leak. So thank you very much, everybody. God bless you. And I'm grateful for your stamina. I apologize these sessions are long, but it's just to make sure that you really get good peer review. I think that's crucial for me. You know, it's really important that you get back. So God bless you all. Thank you so much. Have a good evening.
Thank you. Bye.
Thank you all. Bye.
Thank you.